Yay. Okay, now it's perfect. Sorry. Okay, we're in. We're recording and we're going. Are you ready? You're like, no, yeah, are you ready? I'm ready. All right. So this assignment here, or which would have been an assignment that I know you can't see. Now you see. See this right here? So it says simulation, and then it says here, I am not a monster. Hello?
Yes.
Okay, thank you. All right, perfect. So I am going to, I don't close it, so it's just going to be there. So you guys have access to it. You can actually see it from your, if you were to open up your view, you can see this, right? Because I made it available. Yep, you can, because I was smart. I made it available right now so that you can watch beforehand. So please watch this so we can talk about it next week. It's really, really important in mental health, and it'll show you the difference between somebody who is not stable with schizophrenia and somebody who is stable. And I think a lot of people may not realize how when you're not stable, or most people think that is schizophrenia all the time, and that is not the case. There are many, many functional people that do have schizophrenia. So please watch this. I can't make you, but it would definitely, I think, be helpful, and it's eye-opening, and it will take like 17 minutes. Okay. Any questions before we do our one NCLEX question? That is psychiatric related. Today is psychiatric day. Okay. All right. So we'll get started, and we'll use our tips and tricks, and I'll add some more if I see some. So we have a newly admitted. That might be important. Remember how I mentioned time? So time of all sorts, when they had the procedure, how long ago was it, all of this. So this is a newly admitted client that might count for something. So I'm going to keep that, red flag. Newly admitted client with a history of convulsions. What are convulsions? What are they trying to say?
Seizures.
Beautiful. Exactly. I think that was Virginia. Exactly. Excuse me. So seizures. So a newly admitted client with a history of seizures suddenly says to the LVN, I hear drums. Which of the following should the LVN do first? Number 1, tell the patient to ignore the drums. Number 2, place the client in a darkened room away from the nurse's station. Number 3, continue to question the client. Or number 4, there's a typo. It's fine. I'm sorry. Insert and oral airway. Does anybody want to take a stab at it and tell us what they put and why?
I would think probably continue to question the client.
Okay, and why would you do that? And you're correct.
I would just want to know what else is happening, going through their head, or what they're hearing,
Exactly, because we don't have very much information, right? We're given very little information. This is again newly admitted client, and then we want to look at, so very good. So then we also want to look, I picked this question on purpose because it has a lot going on in the what they're basically the question in itself. So let's go over why the other ones are not good answers. Is number 1, tell the patient to ignore the drums. Number 1, is that therapeutic? This is a psychiatric question, which means it's a therapeutic question, right? It's rude to tell the patient to ignore the drums. That's rude, and it's not therapeutic, and we wouldn't do that as nurses, right?
Correct.
We would never do that. So we know automatically that's not going to be right. Then number 2, place a client in a darkened room. That's not a bad idea. That part is fine. If there were supervision of the client, it's what it says next, away from the nurse's station. Do we put acute new patients away from the nurse's station? Never, right? We want to keep a really close eye, especially if I have somebody with a history of seizures who just came in and is hearing drums. Now, they could be hearing drums because they have hallucinations. It could have nothing to do with that. It could be that they're having an aura because, before a seizure, usually people have an aura of a scent, taste. They might hear something. So maybe that's about to happen. Who knows? We don't know. So we don't want to keep this patient far. We want to keep them close. I want to watch them. And then I'm going to skip number 3 and go to number 4, inserting an oral airway. And the reason why I put this is because it's interesting, because people do pick this one. And I think it's because we shove down your throat, ABC, ABC, ABCs, ABCs, right? But if it has nothing, it has no indication in this question, right? It doesn't say anything about them having trouble breathing. So inserting an oral airway, would that be indicated? No. So we would definitely not insert an oral airway. So we want to be careful to really read the question and really go back and make sure that we reread it, because we can get lost. Our minds can do this, especially again, if you're during the NCLEX, you're going to have some anxiety going on. The only thing I don't like about number 3, it still makes it right, is this to continue to question the client. It kind of sounds like you're interrogating them. So I think they're trying to trick you. That's the one thing I will say. I do think they're trying to trick you, but if you had to go between all of these, of course you want to get more information. I just don't like the way they worded it. Does that make sense? It's kind of like continue to question the client. I don't know. Maybe that's just me, but that's absolutely correct. Does anybody have any questions or other ideas or anything else they see that they want to add that might be helpful? No? Okay. All right. And remember, for tips and tricks, a lot of the times if a question says first, or what do I do first, or what's best, not this question, but a lot of the times, usually you will do more than one of the things. But if it's a question that's not saying, you know, check all of the above or whatnot, and you can only do one thing, usually you'll do all of them, but you pick the thing that you would do first. Does that make sense? So in this question, it doesn't do that. But remember, I think it was day 1 or day 2 that we started doing questions. I did tell you that. This is an example of it not being that way. So I wanted to show you an example of it not being that way, because our last question was that way. And also wanted to kind of show you therapeutic communication and how to really hit home at knowing what to look for and not just always going to that airway. Beautiful. Easy, right? Now, if only every question was that easy. And this isn't easy psychiatric questions or question. In my opinion, psych questions are the hardest. And I'm a psych nurse, but they're the hardest ones on the NCLEX, in my opinion, personally, and pharm, of course. Okay, so we're going to move down to this. And these are going to be questions for you guys. Now, I don't know where you are as far as psychiatric, what you've learned, what you haven't, and all of that. But I don't, and this is not to embarrass or do anything to anybody. But what we're going to do is, so I'm going to give a number to each of you, okay? And I'm probably going to say it wrong, but I'm going to give it a go. Maite? Maite?
Yes.
Okay, you're number 1.
Okay.
Rosa, 2. Virginia, 3. Thank you. Lupita, 4. iPhone, 5. Alice, 6. And Caleb, 7. Okay, so what that means is I'm just trusting that you know your numbers and who is before you. So basically, I'm going to ask questions and you're going to answer. Once you've answered a question, then the next person's going to answer. If you don't know, you say pass, and then the next person goes. Does that make sense? So the first person, of course, the hardest name, but I can't say, I'm so sorry. And another teacher said your name wrong the other day, and I corrected her. But now, of course, I can't say it. So, so if let's say Rosa doesn't know the question that I'm asking her, who's going to go after? She'll say pass, and then who's going to try to answer it?
Me.
Perfect. And then Lupita gets it, and then it goes, and then it just repeats. Okay. So then it's interactive. Okay. So For the first person, can you tell me how long of a hold a 5150 is in the psychiatric world?
Pass. I don't know the answer.
Okay, that's why you're here.
Can I take a guess at it?
And you better freaking know it because we learned it together.
Is it 48?
Very close. Add 24 to that.
72.
You got it. So it's a 72-hour hold, and 72 hours is 3 days. I know you guys know that. I just like to say it all. So 5150 is a 3-day hold. Now we're moving on to the next person. What is, or if you know all of them, there are 3 reasons you can be put on a 5150. Either name one or all of them. Or pass.
Can I just kind of throw a guess at it?
Of course, that's why we're here.
I don't know, trying to hurt yourself?
Yep.
Or
So number 1 would be potential harm to self.
or others?
Boom, exactly. Potential harm to others. And then the third one is always the one people tend to forget.
I don't know. No, I don't know.
Okay, so I'm going to say this one. I want to play. So yes, that's exactly right. So 5150, you must have one of 3 things. You can't just write a hold and say, okay, we're putting you here and you can't leave. And this can be done voluntarily. So if you feel like I don't feel safe and I want to actually go to the hospital, you can go voluntarily. And as long as you're not put on an actual hold from a physician's order, you can leave when you want. But usually, unfortunately, or well, fortunately, because we want to keep people safe, a 5150 is usually involuntary. And that's when you want to hurt, again, I'm going to say it, yourself, others, or you're gravely disabled. And what gravely disabled means in the most simplistic way is you are unable to care for yourself. That's very important. I guarantee this is going to be on your test. If it's not, I'm not going to say it out loud because we're recording. Any questions about that? So 5150, we got it. 3 days. It can be voluntary or involuntary. We know the 3 reasons why. And you have this video to refer back to. I think that would be great for studying. Okay, now we're gonna move to a 5250. And the one giveaway is this right here. I love this too. This too helps me a lot. Does anybody, or the next person, and if you don't, of course, just pass it right along. What is are you guys in mental health right now?
Yes.
And how long have you been in mental health?
Like the whole month of February.
And your instructor has not talked about what a 5150 is?
I'm not sure. I mean, I kind of already knew what a 5150 is, but I just didn't know that. I don't know if she talked about it. I mean, she talked about us about like involuntary, being admitted voluntary and involuntary.
And my eyes aren't mad at you guys. I'm just like, I'm having like a palpitations of like, how can she not tell you that? That's so important. That's like the first thing you should learn. Okay. So, and that's exactly why I wanted to do this, just to do little prep things here and there, and it brings up conversation, and why not? So what is a 5250?
It's a 14-day hold.
Damn, who's that?
That's Elise.
And Elise, why don't you tell me? I've been calling you Alice this whole time.
I get called, I don't trip. I get called both, so.
Okay, well.
But it is Elise.
I was talking about you the other day, and someone was like, that's not her name. I'm like, oh God, I felt so bad. It was good things, by the way. So absolutely, Elise is 100% correct. So remember this too. So a 5250 is a 2-week, which is how many days? 14-day hold in addition to the 5150. So that means you've done your 5150. And then if a 5250 order is written, it's up to 14 days. So it doesn't have to be 14 days. It's up to 14 days. Any questions about that for the same reasons? Danger to self, others, or gravely disabled, which happens a lot because people get checked into the ER and into a psych facility. I'm sorry, it takes more than 3 days sometimes to get someone stable and the help they need, right? 3 days is nothing. Now, if you got, intoxicated and said, I'm going to kill myself because my girlfriend just broke up with me, and then you wake up and you're like, oh my God, I'm on a 5150. I've never had a psych hold. I don't have any diagnoses. I don't know what I was doing. There's different scenarios, basically. But for the most part, if you're going in for 5150 and you're discovering that you may have hit a wall or you're having a really bad crisis, it probably will take more than 3 days. Don't you guys agree? To get somebody stable, potentially either on medication, therapy, both, just maybe sleep. So does that make sense together? 3 days, 14 days in addition to these 3 days.
Yes.
Very good. Good job. Okay. So let's now move down to hallucinations. There are 5 types. So we're going to go down with the first person. So whoever's next, name one type of hallucination.
Is it a visual?
Perfect. We got visual. What's next for the next person? And I like to go down my face, if that helps you. I go down my face. So we have visual. What's this?
Olfactory?
Damn, very good. I love the word too. Olfactory, okay. Next person. I'm pointing on my ear, sorry. I have like a lot of hair.
Am I the next person? Maite?
I don't know. I think Caleb comes in somewhere.
All right, auditory.
Auditory, exactly. And then what's the last one? Which a lot of people are unfamiliar with. When you eat, hopefully starts with a T. Taste. So you might taste like metal or feces or who knows. I've heard many interesting things and wondered how they knew what it tasted like. So we have 5 types of hallucinations. For now, these 3 together, hallucinations, illusion, and delusion. These get mixed up a lot. So I'm going to put these 2 to the side for just a second. And whoever's the next person, can you tell me what SI stands for in the psychiatric world?
Am I the next person?
Let's start over with number 1. So number 1, so yes.
I'm again not sure, but I'm thinking it's suicidal ideation.
Damn, good job. See, take a chance. You got it right. Suicidal ideation. Next person, what is suicidal ideation? Rosa.
Or just the idea of wanting to commit suicide?
Exactly. It's a thought. The ideation is that you're thinking about it. But when we ask a patient, we don't usually say suicidal ideation. That's more for documentation on our side, but that could definitely be a question. But just as a side note, when I'm talking with patients, I don't say, do you have suicidal ideation? I would usually ask something of, do you have any feelings of harming yourself? Any plan of harming yourself? And that's the way, of course, and my voice will always change when I go into patient mode. So that's exactly right. Very good job. Okay, now we're going to come back up here. Does anyone know, and now anyone can answer this question, and if you get this right, I might just fall out of my chair because I still get these confused, and it's been 12 years. What's the difference? Illusion. It looks wrong, but what is the difference between an illusion and a delusion? Jesus. Does anyone know? Does anyone know what a delusion is? Okay, so we'll start with illusion then. So an illusion, you guys have probably all seen, like if you're driving down the street and you see it's really hot and you see it looks like water. And so that would be like an illusion. So you're seeing something that's not there. So that's how I remember it. So an illusion is basically, so what is this? my phone. So this is my phone. I can see it's my phone. We can all see it's my phone because none of us are having psychosis. So remember, psychosis is a detachment from reality. That's what psychosis is. It can be in many different realms of different diagnoses, but on its own, that's what it means. It's a detachment from reality. So to me, if I'm having a detachment from reality and I'm having an illusion and I'm petting this and you walk by and I'm like, oh, come pet my dog. So it's basically, there's a real thing. There's something real that's there, but it's not what it is. So this is hand sanitizer, but I think it is a toothbrush. This is a mouse to a computer, but I think it is a pet snake. So that's an illusion. It's an actual object, but it's not what it actually is. I think it's something else, but it's not what it is. Does that make sense?
Yes.
Okay. A delusion, think of the brain. A delusion is something where usually you're going to hear people say, I have a meeting with the president today at 2:00. We're going to be talking about the government. I am part of the CIA is watching me. That has to do with more mental distortions. So if you hear CIA or president, think delusion. So your brain is what did I just say? It was like perfectly said. It's when your brain it's in the recording. Watch it again. I said it perfectly. It's really hard to explain. And I try to keep things simple. So illusion, I think, is easier because it's like, oh, okay, this is in a phone. And delusion has to do, mental distortions. So mental distortions versus visual distortions. Does that make sense? So an illusion is a visual distortion. Delusion is a mental distortion. And usually has something to do, not always, but with like CIA, police, paranoia. If you hear that, usually that's a delusion. Any question about that?
So a delusion is a mental and illusion is I'm sorry.
Yeah.
Uh
And an illusion would be, it's more, it's an actual physical, something's really here. So a hallucination would be like, hey, don't you see that Biden's sitting right there and there's no one sitting there. There's no one sitting in this chair next to me. Yes, it is. He's right there. Now, if my worker was sitting right there and I was like, oh, there's a telephone pole. Do you see the difference? A hallucination is nothing's actually really there. And then the illusion is I'm mistaking a human for a telephone pole.
right. Okay.
And that's why I record these so you can rewatch them because, girl, like seriously, this is not easy. I mean, even for me, sometimes I'm like, what's the difference between an illusion and delusion? Like I have to take a second. Hallucinations I've got down because I deal with that a lot. But these are, I want you guys to know this. I want you to understand them because I think it's really important. And it could be on your test, who knows? Especially ATI. If it's ATI related, it probably will. Good job. Okay. Now let's do a couple questions. So whoever's next, and if you don't remember who's next, we're going to start with Lupita. I don't know if you know whose turn it is, then go. If not, then go Lupita. Okay, questions. True or false? Can a medication be used as a restraint?
True.
Exactly, yes. And many people don't realize that. Absolutely. If I dope up my patient with Ativan because I can, and it's an as-needed medication, and I just keep giving it and giving it and giving it because I want them to leave me the hell alone, and it happens all the time. And it's really sad. I understand it. I get it. I work in mental health. I understand it can become quite intrusive for somebody to constantly be in your face and need something or want something, but it can be. That's a restraint. You're basically doing a restraint for the reason why you're doing it. So absolutely. Very good. Any questions about that? This is very important. And this actually was on one of my recent students' NCLEX, by the way. That's why I put it on here. And for some reason, if this hangs up, I have 11% battery. And of course, I didn't bring my charger because I was like, oh, it's going to be full. I had 100%. I don't know why. Like, I think the P is seeping down to like the motherboard. So again, I'm sorry, this class is like a little bit and not as organized and sophisticated as it usually is. Okay, what book is used to diagnose mental health diagnoses?
DSM-5.
Excellent. I'm assuming that Caleb's the only dude, right?
Yes.
You're okay to be called dude, I hope. Okay. And he's driving and he's still here. Good job.
No, my girlfriend is driving.
Okay. Please take her. Good. Okay. So what is the most prominent neurotransmitter in schizophrenia? So when I say that, I mean this. So any type of mental health disorder, of course, as we would probably understand, is that it has to do with the brain, correct? And we have neurotransmitters in our brain. And I'm not going to go too deep into it right now because we're hitting the kind of building a small foundation, and then I'm going to basically go way more into depth the next time, and it will actually be an hour and a half. Today, because of the circumstances, I do apologize that it's just not, and you don't have any homework. This was supposed to be an hour and a half, and I unfortunately don't have my charger, and I have 10%, and I'm at work, and now I'm going to have to work after this now that I'm done with clinical. So I do apologize for that. However, at least we're still here, right? So we're still getting something. And please send me some questions if you guys have any sort of questions on any of this mental health stuff. If you want me to go over it, I'm happy to. I'll even make like a private video and post, not private, but put a video without you having to be there if you want to watch it. Okay, you can even send me an email. So the neurotransmitters in our brain. So the next person, I'll just ask you this. When you're depressed, what is usually one of the number one neurotransmitters that's involved? It starts with an S.
Serotonin.
Exactly. And Caleb was not next, but yes, good job.
Oh, I'm so sorry. Dang.
You should be sorry. Fine. No worries. So yes, serotonin, that's perfect. So this is how we make our connections and remember things. So with schizophrenia, there is a specific neurotransmitter that, yes, there are a few that are involved, but there is a one that's mainly involved. Does anyone know which one that is?
Dopamine.
Yes, very good. Dopamine. So too little or too much? Anyone? Do you have too much dopamine or not enough?
Not enough.
Not enough.
Actually, it's too much. So all those positive symptoms, they call them positive symptoms of delusions, hallucinations, all those things, is because you have so much dopamine flooding through your head. And so now that you know that, now I just told you that, now let's make a really beautiful connection. And this is where maybe it's more magical for me, but the magic happens. We're going to connect it. Schizophrenia is, now again, we're thinking small terms. I mean, there's obviously more reasons why it happens, but the main reason why you're having the symptoms that you're having and seeing in those who are schizophrenic is because they have too much dopamine. So how do you think an antipsychotic works? If I'm going to give my patient an antipsychotic, what is it going to do to the dopamine?
Block the dopamine.
Decrease it.
It's going to, exactly. Yes, and yes. Exactly. So do you see the connection? So you have too much. I'm going to give you an antipsychotic. So if I came up to you when we were passing meds and I just said, oh, hey, I see you're giving Abilify. What does Abilify do? Oh, it decreases the amount of dopamine in the brain for this specific patient. That's why we're giving it. Remember, medication can be used for different reasons. So just because you're taking an antipsychotic, I take an antipsychotic at bedtime, 12.5 milligrams of Seroquel, which is nothing because I can't sleep. Has nothing to do with my dopamine. It doesn't even hit that part of my brain. Now, if I was taking hundreds of milligrams of it, then yes, it's different. So there's a therapeutic index. I don't want to make it too confusing because again, I'm trying to keep it broad today and then build. So we have a patient, they're schizophrenic. That means too much dopamine. we give them and keep them on antipsychotics, and then it's going to keep the dopamine low so that hopefully those symptoms stop, right? That's the hope. So I'm going to ask one more time. So schizophrenia, too much or too little dopamine?
Too much.
And antipsychotics do what with dopamine? Make it lower or higher?
Lower.
Beautiful. And what is the medication? It's my favorite, one of my favorite ones to say out loud. Let's say we lower it too much. When you lower it too much, you know, when people have Parkinson's disorder, that's because they don't receive enough dopamine in this part of the brain, in the middle part of the brain called the substantia nigra. You know how you start to notice shaking, drooling, some really unfortunate symptoms. You can actually cause your schizophrenic patient or anyone who's taking antipsychotics at a usually pretty high level or higher level. You can actually throw them into what's called Parkinsonians, or tardive dyskinesia is also a name that's used for it. I like the word Parkinsonians because it goes together and I like connections. So we don't want that, right? We don't want that either. We want to try to make our patient comfortable. So we can do one of two things. We either adjust the medication and hope it works, and sometimes it does and sometimes it doesn't. Or there's a special Band-Aid, I like to call it Band-Aid medication we can give. So my patient's having Parkinsonian. It's not terrible. There's some tongue rolling. It's not super comfortable. What's the medication that starts with either a C or a B, depending on which one you use, that you can give to help offset those symptoms? It starts with a C or a B. My computer it's gonna die in about 3 minutes, just in case I lose you.
Is it levodopa, whatever it's called?
That is-
LE.
That's an amazing, like literally the best guess I've ever had, or best answer that wasn't correct that I've ever had, just as a side note, because it's good critical thinking, because that's what we give people who have Parkinson's, so good job. It's actually called Cogentin, or I can't say the other word, that's why I say Cogentin.
Propane?
Or benztropine, yes, thank you. So it's an anticholinergic medication that we can give to help offset Parkinsonians if our schizophrenic patient is having side effects from their medications, like the tongue rolling, drooling, shaking, odd gait, things like that. So do you see all those connections that you just made right now with the neurotransmitter that's causing symptoms, what is happening in the brain, what we do to decrease it by giving this medication, how it helps, and now what we can do if the medication goes too far the other way with just one diagnosis. Do you see that? How beautiful that was? Or was that just me? Maybe I'm just that much of a nerd.
Yeah, it was really helpful.
So, and the reason I'm doing this is because next week, bring your game, because it's on. Like, bring your brain, bring your game. That's one reason why I didn't give you homework as well. Please watch the schizophrenia oh my God. I need to eat. I haven't eaten yet today. Please watch the schizophrenic videos. Please. You don't have to. I can't make you, but please. There's no homework because I want you to study for your test. When is your test? It's this month. The 5th?
Next week.
What day? Will I see you first?
Yes, we have the mental one, I think, on Wednesday, and the theory one on Tuesday.
Perfect. Bring your game because we are going to get down on Monday. I want, please, if you can. So Lupita and Rosa, we'll talk later about the other thing that we're going to talk about for tomorrow, because I don't want my computer to die on you guys. This is going to be recorded. It will be uploaded. Unfortunately, not right now because my computer's going to die. And now I'm going to have nothing to do for the next hour. And I'm at work doing nothing. Look what my kids got me. They got me a gift basket because it was a really bad week last week. Is that not the nicest thing in the whole world?
Oh.
Yeah, that was really nice.
I cried. Of course they're so cute. Oh, anyway, sorry. You probably didn't even see it, but it just made my whole day. Just people still being kind in the world. It's like, oh, They could have just got me a card and I would have been in heaven. Okay. So this was an introduction. I'm sorry. Okay. So this is kind of an introduction. Please, 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 if anyone has some time, if they can shoot me some sort of text or something to give me some direction on what you've been studying. And I thought about some medications we can go over, like Rosa and Rosa and I think we talked about this. Remember Medication Madness, how I teach you about serotonin, medications that affect serotonin, norepinephrine, and how to remember them, and it was super helpful, right?
Yes.
So I'm going to do that, but if you have specific things, please let me know. And next week it'll be the same thing. We're going to do an hour and a half because I'll have like a new computer that's not pissed into that's not destroyed. And unless someone steals it from my door, because it's there right now. None of you know where I live. Nope. Okay, good. That was a joke. So Caleb's like, honey, drive to South San Jose. So really today is sweet and short, or short and sweet. Not on purpose, but because of the malfunction of my computer, and I apologize. So I will post this. Please watch the schizophrenic video. Send me anything you're interested in learning. Next week, same thing. Will be no homework. You guys are overwhelmed enough. If it wasn't for anything, we wouldn't even have class, but I want to help you with your mental health stuff. So we'll do that. And that's it. Short and sweet. Just
Thank
like
you.
Thank you, Ms. Clay.
Thank you guys. Thank you so much. And I hope you have a good rest of your day. I'm going to go save lives now. And it was nice having our new people here with us today. Welcome to class.
Okay.
Thank you.
Thank you.
Have a good one.
Later.
Have a great
Bye.
day, guys. Thank you.
Bye-bye.
Bye.
Bye. Thank you.
Thank you.